Thank you. Thank you for the invitation. There's been a renewed interest in the United States in trying to become more robust about how you improve quality in all hospitals, but in particularly in academic medical centers. And the most widely known one is called high reliability healthcare. This is emphasized by the Joint Commission. I don't know if in Europe if you're familiar with this, but Six Sigma, the idea of trying to be very precise and having things robust and very reproducible. More recently, there's been this idea of learning health systems, and this has been highlighted by the National Academy of Medicine, and it requires you to look at your own data, to systematically use that and integrate external evidence with the idea to bring new knowledge into practice. And because of COVID-19, we thought, is there some possibility to accelerate this in order to get changes more quickly integrated into the health system? And does anyone know who said, never waste a good crisis? No? Winston Churchill, who is more popular than your current prime minister in England. But we tried to say never waste a good crisis and see if we could do something quicker. And we coined highly reliable learning health system. And this is trying to get away from silos, that you use the clinical operations, the electronic health record, information support, clinical research infrastructure, AI. We even used people from the computer science department across the campus to try to get a process that went more quickly than our current process. So we set up what we called a choir, which is an acronym for a committee that rules on all this. That you bring your good ideas to this committee. It has everyone from physicians, nurses, pharmacists, quality improvement people, researchers, institutional review board, because some of these require an IRB approval, medical education people, and project managers, who are professional project managers to do this, because we as physicians are not so good at this. And we provide support. My contribution, this was my office paid for this, so that was my major contribution to get this to go. And it's very multidisciplinary. It's not the usual siloed effects that we see in academic healthcare. And we use the outcomes both to change the hospital, but also to publish this, with the idea being that this is an academic pursuit, it should be published, as well as improve healthcare. So we had some early wins. These are very simple things, but they did go very quickly. We set up rapid COVID PCR testing for our students, and we were doing 10,000 tests every day, returning the test within 12 hours. So that was using an academic research lab to do PCR testing for the San Diego community. We use an artificial intelligence algorithm, this is very early, to diagnose COVID by chest x-rays. Apparently there's some findings that AI does better than our radiologists, which might be a lesson not to go into radiology in the future, to be able to make diagnoses and not confuse them with other pulmonary diagnoses. We set up one of the country's first vaccine superstations. We're doing up to 10,000 vaccinations a day. We also, but by keeping track of our own people, our own faculty and staff, we were one of the first places to show breakthroughs for people that were already vaccinated. And the CDC used that to recommend the boosters, that data to recommend the boosters. That was published in the New England Journal of Medicine. And we also tracked how we did with cancer. There's actually a big delay in people presenting with cancer early during COVID, and we're able to track that using this system. Okay, so the one I'm going to tell you about, though, is something that's currently going, we're doing data all the time, but it reflects this idea about how you can combine different aspects of an academic health system. And the question we wanted to determine was, we saw thousands and thousands of patients with COVID, and many of them were patients, and unfortunately many were also healthcare workers. And the question was, where was this being transmitted? Could you use this type of approach to determine where people were getting their COVID, and what were the risks of being in a hospital, how much of it was iatrogenic? And a lot of staff had COVID. Did they get it at home, or did they get it in the hospital? This was, as I said, this was approved by this committee we set up, the Acquire Committee, that let us do this project. And this is kind of the pathway that we used. So this did not project that well, but I will tell you. So this was presented to the committee. They then looked at the EPIC. We use EPIC, which is the largest used electronic health record in the United States. I guess Cerna is the largest in Europe. We put the EPIC data together with all of the sequencing data. We made a commitment to sequence every patient within a week. So every patient had their full sequence available. Then we overlaid the sequence data with an EPIC. This is almost like Facebook, where you can look at EPIC and see who was who together in the same room, in the same part of the hospital at the same time. And so you can make like an interactive chart and then impose that on the actual genetic data. And that way, it doesn't matter. You can have people come and get very similar sequences, but they had nothing to do with each other. You can show they never were in the same part of the hospital at the same time ever. And you can eliminate those as being hospital acquired. Okay, so this is what the data looked like. The concept was that if it's an identical genome, it was a match. If it was off by 1 or 2, it would be further up on the phylogenetic tree. This is what the data looked like. This is only Omicron. It took 2.5 months to do this. The Omicron variants are continually evolving. And what we learned was the following, that we could identify multiple clusters. And initially, it looked like an enormous number of people had similar clusters in the UC San Diego health system. But it turned out that if you model this and make a prediction, the model predicted to be no more people involved. Sorry, it's shown here. Oops. Wait, vaguely. Then you can. Sorry? Thank you for participating, though. I would appreciate that. And there'd be no more people than you would have predicted by normal chance interactions. So this, as a very high level, the key insight is that we did not see more people infected in our system than was predicted from the community. Okay. So we identified multiple clusters, and in each cluster, we looked at the temporal relationship between the physician or the healthcare worker and the patient. Could they physically be at the same point at the same time? And that in multiple of these, it was very unlikely. In other words, we could not find any reason they were in the same place at the same time, even if they had very similar sequences. And that allowed us to go on and look in great detail in the clusters that we can document where they could have potentially been in the same room or the same area at the same time. And one example that we would have missed by standard technique is shown here, where there was a dietitian. This is RD. She interacted with the patient, and then she came down with COVID one day, and a day later, she was diagnosed one day, but she was infectious when she saw this patient, and the patient got infected. So there was an example where, unfortunately, this was iatrogenic. This was an example where a dietitian gave a patient COVID. Okay, but when we overlaid and looked at the entire data, the results were actually, I think, quite encouraging, that the vast majority of the pairs did not turn, these are pairs determined simply by genetics. But when we overlaid this with our EPIC data and the actual interactions of people, the pairs dropped down tremendously. So there are only 40 clusters that we could identify. So this is our general result, is that even though there were an enormous number of people in the system that had almost identical genetic profiles, they did not get their disease in the clinical environment. They got their disease in the community and brought it to us. And so we could distinguish iatrogenic, which we said if you're in the same place and you have the same genetic variant, that's iatrogenic. But for everyone else, it had to be brought in from the community. Okay. This is a cluster that unfortunately is iatrogenic. This is Hillcrest. Hillcrest, we have a couple of hospitals. Hillcrest is the oldest. It's almost 60 years old. It's by far older than any of our other medical facilities, and we were concerned, appropriately, that maybe there was more risk. Even though it fulfills all the obligations of ventilation and everything that's required, there are probably areas in common spaces, in the hallways, that are not as ventilated as optimally like the new buildings, and therefore we were concerned with the risk. And this is a really good example where two patients share a room. They actually, in this older hospital, actually are shared rooms, and in new hospitals are not. They interacted with a nurse and an occupational therapist, who in turn interacted with an ancillary person. And this cluster is all the same genome. So this was done in the hospital, several steps that was caused by this. So just for comparison, this hospital is almost 60 years old. Anyone know what the oldest hospital in Florence is? Someone from Florence, so. It's the hospital of Santa Maria Nuevo, 1288. It's still being used. Yes. Yeah, still being used. So the ventilation there might need some work also. Okay, in a little more detail, we looked at, of all the cases, there was no overlap in the vast majority, so they occurred somewhere else. But in 15% of these cases, we looked at Omicron transmissions within the UCSD system. Some of them were clearly because of overlap, definitely. But when we look at where they occurred, again, the majority, even though these hospitals are the same size, the majority occurred in the older hospital. So one of the take-home messages was a need to look at the ventilation in these areas. Well, a comparable size hospital, Jacobs Medical Center, much lower, same size hospital, but much lower. Okay, so these are my take-home messages. That in 45 out of 46 clusters, we can identify them using existing infectious disease protocols. We picked up a cryptic one, but it really shows that contact tracing and other infectious disease prevention protocols work. The transmission occurred more often in our older Hillcrest campus, probably reflecting ventilation in non-patient areas. Most of the known clusters that did occur in clinical areas, they were able to identify a breakdown in the systems. Either patient or staff was not masked, or there was a lapse in PPE, in personal protective equipment protocols, and that probably reflected this. But the real bottom line is that this analysis showed that the majority of healthcare workers, the COVID-19 infections were not from acquired patient care, but they were from the community, and that transmission, especially between patients and healthcare workers, rarely occurred in the healthcare setting. And even the few that did occur, you could usually find a breakdown or something that we could do better. So I think this is very encouraging. I think the system clearly worked. This was done in 2.5 months. When we used to do this on a more leisurely time scale, this would take years to do. So I think that the ability to use the incredible strength of an academic medical center to actually make decisions in real time, I think is really well documented here, and it's a good example for all of us. So I will stop there, and thank you for your attention.
Thank you. Now it's time for one question.
Sal wants to ask something. He has this urgent need to ask something.
Really fascinating result, David. Could you please clarify what about after the La Jolla hospital compared to Hillcrest? Was there any data that comparing the two areas?
Yes. So Sal's visited us in San Diego. We have one brand new hospital and one old, very old, relative to the United States, very old hospital. And the Jacobs Medical Center, the new La Jolla Hospital, had incredibly low rates. And the patient population is very similar. The doctors are all the same. The staff is all the same. We attribute it to actually the actual infrastructure. And there's a lesson there that the ventilation, the way we do things, could be better. And the new buildings are ventilated better. And it's a big concern with older hospitals about infection control and how to do that better. So thank you for that question. I will stop there. Thank you.